Hello, everyone. Thank you for coming. Got a really interesting speaker today who you'll meet in a moment. I think everyone knows who I am. I'm Tom Chandler. I'm the dean of the college. This is our second annual Gerry Sue and Norman J. Arnold Childhood Obesity Lecture. And I wanted to start just telling you a little story. Norman died almost 2 years ago, August of 2015, and about a year before he died, I got a phone call really out of the blue, which Norman liked to do because I think he could sense it kind of put me a little bit on edge, because Norman's our benefactor. But Norman called me out of the blue and he said, Tommy, you know, I was in Target yesterday and I was in McDonald's this morning, because he'd almost every morning he would go down to McDonald's, which was near his house. And at that time, and then maybe they still do it, you could buy like a refillable coffee mug. And Norman liked the value of $1, okay? And he would go down there and he'd get his morning coffee. And he said, Tommy, I'm damn tired of every time I go to Target and every time I go to McDonald's seeing all these fat kids who can't move. And he said, what are you going to do about it? He said, let me rephrase that. What is my school going to do about it? And of course, fortunately, I had a whole cadre of wonderful researchers working in this area, and I could talk to Norman about things that were being done. But Norman, in his own way, decided he needed to do something, and he came back and he endowed this lecture, plus he even gave more, and we now have a very nice endowment to look at the issue of childhood obesity, particularly in South Carolina, but certainly as it applies nationally. Nationally, 20% of all school-age children today are obese. The rate in our state is even higher. And I was talking to Brian a little bit about this earlier. We now rank 48th in the nation for obesity, with 39% of our youth overweight or obese, which is what Norman saw. And of course, the follow-on problem of childhood obesity is adulthood obesity and the chronic obesity-related diseases that are such a problem in our state, such as heart disease, stroke, and especially diabetes, where we now rank 43rd worst nationally with diabetes. It's a seemingly intractable problem for many folks, and as Tom Frieden, our former CDC director, said recently in a JAMA article that he published, he said, no progress has been made in reducing childhood obesity. No progress. Well, I disagree a little bit with that statement, because I can tell you we do have investigators here in the Arnold School in this room, folks like Russ Pate, Michael Beach, Glenn Weaver, Sarah Wilcox, Ron Prince, who I don't think is here today, Dawn Wilson, and others, and especially this amazing guest speaker that we have here today, Brian Saelens. They've all been working very hard and I think making great progress for solutions to this difficult problem. The challenge is, how do you move the needle? And that's what we're going to hear about a little bit today. And I certainly remain optimistic. And I know Norman will be very proud of the efforts that all of you and your students have made in this particular area. So at this time, Michael, if you'd come up and introduce our speaker. And Brian, thank you so much for visiting with us all the way from Seattle. So thank you.
So first of all, I'd like to thank everyone for coming, and thank you, Tommy, for that little introduction. And importantly, I want to thank Gerry Sue and Norman J. Arnold, which I know would love to be here today, because without their passion and their financial support, we would not be here today, be able to put on a talk like this, and also to make some changes in children's lives throughout the state and hopefully throughout the country. But before I introduce today's speaker, as part of the gift that was given for childhood obesity, we also created a Emerging Scholars in Childhood Obesity Graduate Student Award that we've been giving annually. This was our second annual one. And this is a part of this initiative is that this is to support the continuing professional development of those Arnold School of Public Health, both master's and or doctoral students that are demonstrating commitment and passion towards childhood obesity. And so I want to take some time here now to introduce this two fine students that the awards go out to Carlene Mayfield and Alicia Dahl. So congratulations, and we look forward to having you as colleagues. So now on to introducing our speaker, Dr. Brian Saelens. So just as a general background, I'll give some academic stuff here. So he's a professor of pediatrics and psychiatry and behavioral sciences at the University and the principal investigator at the Seattle Children's Research Institute. His educational background is he trained and received his PhD with Lynn Epstein at the University of Buffalo. Many of you know who Lynn Epstein is and have followed his work, so that's a great pedigree. He also did his postdoc with Jim Saelens, who was our initial speaker here, so I think we're having some great lineage there. And he started his faculty career at the Cincinnati Children's Hospital in 2000 and has since been in Seattle since 2006. His research interests have a strong community focus and largely are on the prevention and treatment of childhood obesity, and also to identify strategies to improve family-based care and weight management interventions for youth with already elevated weight status, in which he'll be speaking to us today about. But he is also a renowned expert on environmental correlates and factors related to physical activity and healthy eating. So that is another arm of his research agenda that, while he won't be specifically talking about here today, if you have that, if you're interested in that area, Brian Saelens is one of the top individuals within the country. And Brian has been an impressive and highly active scholar. So according to Web of Science, his H-index is 54, which means that he has 54 publications with at least 54 citations to them. Google Scholar, which we all prefer because it always has higher metrics, has an H-index of 72. He has 5 publications with over 500 citations each, and his most highly cited article, do you know what that is, Brian? It's Environmental Correlates of Walking and Cycling, Findings from the Transportation, Urban Design, and Planning Literatures. It has 964 citations, so if you're writing anything, go out and cite this so we can get him to the 1,000 citation club. And over the last 10 years, according to Web of Science, he's averaged 18 publications per year, so a pretty impressive track record there. And according to NIH Reporter, he's garnered over $14 million in PI funding. So very impressive, and I think that's a credit to all the great work he's been doing. But what I like to share here is some of the smallness of academia and how paths typically cross, and I'm sure we all have stories about how paths have crossed in one way or another. And so I remember very vividly, and I'm sure Brian remembers this incident very vividly as well, that Brian interviewed at Oregon State University where I was a doctoral student, and I remember sitting there watching him interview for, I think it was an assistant professor position in spring of 2006. Yeah. And so that was the first time I met them. Subsequently, many years later, he was the chair of an NIH review panel for testing interventions for health-enhancing physical activity, of which I was a study section member. And since then, and I believe I've either begged or groveled, which neither of them are beneath me, to get him to be part of some of our studies that we're doing, and he's a co-investigator on many of our new grant applications, both funded and soon to be funded. And so he is a tremendous individual, and we look forward to your talk. Brian?
Thank you so much for the invitation and the warm welcome. Funny thing about that publication, the one that's most cited, it was rejected by a journal that we were writing it for because they said we had too many references. It was a review article, and they had a limit on the number of references. And we fought back, we pushed back and said, you know, one of the things we're trying to do is actually to get folks within physical activity and health to be exposed to the transportation literature because they talk about walking and pedestrian things. And they said, nope, we just won't publish it. So we went to another journal, and apparently it's well cited. Maybe they rue the day or they don't even care, I don't know. This just came across my email, so I want to provide this provides a context for some of the things I'm going to talk about. Over the past year, there's been a lot of communities that have passed sugar-sweetened beverage taxes as a way to try to mitigate some of the consumption that kids in particular are having regarding sugar. It's a high proportion of added sugar that kids get in their diet. The Michigan State Senate just passed what they call the Food Access and Affordability Act to prevent cities from actually passing any taxes around food, saying taxing food hurts families, farmers, and local businesses. The Michigan Food Access and Affordability Act ensures Michigan families can count on affordable, tax-free food and beverages, and we urge Governor Snyder to sign the bill into law as soon as possible. Obviously, we're trying to tax fruits and vegetables, so they want to prevent us from doing that. That's not true at all. We're trying to actually have kids have more healthful environments so that the interventions I'm going to talk about actually have some impact and broader impact and things that kids and families can sustain over time. So I'm going to talk very briefly about the scope of the obesity problem, right? You guys know this stuff. I'm going to talk about what our model of family-based treatment is and its implementation and how I think about behavior change with the families that we're working with in these interventions. Talk about the evidence for family-based treatment, what I think are the needs for evidence-based family-based treatment, and then an alternative delivery model of it. Folks have seen these slides before. Back when I was growing up in the 1970s, only about 5% of kids actually were above the 95th percentile. Made a lot of sense. By the early 2000s, we were in the 15 to 20% range. Looking at things over the past few years, people get excited about the fact that, well, it seems like we're stabilized. Stabilizing at 15 to 20% of our kids being obese isn't a good place to be. The fact that we're not going down suggests we need a lot of more aggressive strategies to actually address that. And our rates of extreme obesity aren't slowing down, right? They're increasing, and they've increased over the past 10 to 15 years. As Michael mentioned, I do work at the community level, at the school level, at the state and federal, local policy level. But today I'm going to focus just here. And why I focus there is because I think there is power to harness regarding caregivers and parents and other kids that take care of, other folks that take care of kids. And I think this is part of the solution. Another reason I focus there is I think even with the most aggressive ways to try to do obesity prevention, we're not going to help the kid who already is struggling at a high weight status. And we need options and opportunities for those kids and those families so they can have a better health prognosis in the long term. So the obesogenic macro environment I just alluded to, states passing laws that preempt local municipalities from taxing unhealthy foods, to non-walkable places, to ubiquitous availability of unhealthy foods. In that obesogenic macro environment, this idea that you can get an individual to have their energy intake exceed their energy output is pretty easy to do. Right? That's how you end up with 15 to 20% of our kids being obese and a third of our adults being obese and 2/3 of them being overweight. This idea of, well, if you're balancing energy intake and energy output, that's still hard in that macro environment that's encouraging people to make less healthful choices. And this idea that, wow, you can get energy intake to actually be lower than energy output is very hard to do. One of the things I won't talk about, because I don't know it as well, but also because I'm maybe somewhat fatalistic about it, once adults are obese, it's really hard to reverse that. And the data on adult weight management trials suggests that, within 5 years of treatment completion, most adults are back to their baseline weight or even higher. So what do we do? We've got kids who are struggling with weight at a very young age. What are the components of treatment that we focus on? For folks who took Psych 101, a lot of these things will sound very familiar. And I'm going to go through this slide pretty much in detail so that it frames the rest of what I talk about. Most of our families come into treatment not having a good sense of actually what they're eating or how much physical activity they're getting. And so the first thing we teach families to do in our weight management programs is to self-monitor and parent monitor the food and activity that child is engaged in. What does that do? It increases the daily awareness about those things and very relevant and specific to the decision-making scale that you want these families to make changes on. If you're not monitoring your intake throughout your day, even at the end of the day, you can't make better decisions the next day regarding making more healthful choices. Second, it provides data for goal evaluation and accountability. So one of the things we do with our kids and families is we set goals and we have contingencies based on meeting those goals. Those goals are around diet and physical activity. I'll talk more about those in a minute. Without that monitoring, it's hard to get that accountability. And lastly, it allows for an opportunity to be building upon success. A lot of the things that we see within our families within treatment is it's slow progress, and oftentimes it's hard for them to see on a week-to-week basis, but when you go back to when they first monitored, there's significant changes in the eating and activity their kids are doing. We do goal setting and contingency reinforcement and management. That's very behaviorally focused. It's not focused necessarily on weight change per se, but it's focused on changing the behaviors that we think relate to better weight management. And it's time scaled for success, so the kids are getting immediate feedback regarding their goals and rewarded immediately after meeting those goals. We talk to our parents a lot about environmental control, trying to change the home environment so your kid has less access to less healthful foods, has more access to more healthful foods, and to try to change other environments in which that child, as much as a parent or caregiver can, to make it so that child, the easy option is the more healthful option. And lastly, at least within our program, and this is somewhat inconsistent with some other obesity weight management programs for kids, at least that exist in the community, parents are provided the same goals and expected to do the same things we ask our kids to do. Gives you a sense of what we teach families and what we educate them on in our family-based treatment programs. What's the format of it? Our current format of our intervention, and within most of our intervention trials, is a 20 to 24 weekly sessions that we have with them. That's consistent with the intensity recommendation of the 2010 and the recent 2017 U.S. Preventive Task Force services. How many folks have seen a provider for 20 or 24 straight weeks and not be unhealthy? The format was we have individual family sessions and parent-child dyad sessions with families every single week, and then they have separate parent and child group sessions, 40 to 45 minutes, and treatment is provided by trained healthcare providers, behavioral interventionists, including myself as well as my team that deliver a protocol-based delivery with individual family tailoring to it. Why do we think this works? How do we think this works? I talked about the skills I just referred to, monitoring and goal setting, contingency management, and parent modeling. To me, those are the core skills that we encourage families to teach families how to use. We train them how to use those things. We provide them feedback about how well they're doing with those things, and we hold them accountable for doing those things on a consistent basis in a way that actually increases, hopefully, the likelihood of the use of those skills, which leads to behavior change, which leads to weight and shape changes, which hopefully leads to them feeling efficacious about these things, and hopefully this cycle starts to perpetuate itself. If you do these things and don't see this behavior change, you stop doing these things very quickly. Why do you stop doing them? Because they're very arduous and challenging to do. How many folks are parents in the room? How many folks have monitored their kids' intake for 24 weeks? Every single thing they put in their mouth. It's a very arduous, difficult task to do. How many folks have goals for their kids around physical activity and healthy eating? Some do. Excellent. If you do these things and you see effects of those things, you keep doing them. If you do these things and you don't see effects, you stop doing them very quickly. If you don't provide feedback about how well the parents are using the skills, some parents and caregivers think they're using those skills very effectively and very well. If as a professional interventionist you don't think they're doing that, then they think they're doing something that actually doesn't have an impact. They'll stop doing it because it's not having its impact. You need to provide feedback about how well they're doing those skills, and you need to hold folks accountable for doing them. Underlying this, so to me that's the behavioral model. That's how we think we get behavior change within the interventions that we do. I was talking about this with my kids, 13-year-olds. I have twins who are 13 and 11-year-old. And one of them said to me, well, gosh, Dad, that doesn't seem like rocket science. And it's not. And that's an important point that I'll come back to. Beneath that, or kind of accompanied with that, we have a model of nutrition and changing diet that we think is healthful, as well as helps kids stop rapid weight gain, which most of these kids are engaged in. We think that knowledge about nutrition is necessary but not sufficient. If it was sufficient, we'd have a much healthier population. We also believe that most overweight children and adults are not eating in a readily observable way different from their non-overweight counterparts. One, because it's difficult to see what is different. Most kids aren't eating very healthfully. These kids are probably more predisposed to putting on early weight, but a good 1/3 of their classmates will also be overweight as adults, so it's not like these kids have great eating habits to start with. And that change needs to be substantial in order for it to be noticeable, and in order for it to impact weight status for the kids as well as the parents. Change needs to occur in terms of the amount of food they're eating as well as diet quality, and that more information, particularly for kids, is going to lead to actually more confusion, right? So we don't spend 10 weeks talking about macronutrients and micronutrients and how those interact. We try to take a very simple approach so our kids can understand it and parents can understand it in a way that they can implement. Again, daily food monitoring for specific characteristics we encourage them to monitor. We use a stoplight eating plan, a la Len Epstein's work, although we've modified what we consider green foods, yellow foods, and red foods. We do it based on dietary fat and sugar, based on food groups. There's more regular existing, for example, sugar and dairy products, or cutoffs for sugar are higher for dairy than they are for meat per se. We set daily caloric ranges for kids in order to be a healthy weight change. Sometimes these are too low, so we up them if kids are losing weight too quickly. This is actually a modest caloric reduction for most parents, maybe not relative to what they're currently eating, but certainly relative to what other weight management programs do for adults. And then we gradually help them reduce their red foods to be lower throughout each week. Our physical activity model is also hopefully something that's feasible for parents and kids to do. We think that kids and parents need to do more physical activity than is recommended for general health. One of our prior studies suggested that if kids are getting at least 90 minutes of physical activity, which is 50% higher than the recommendation, they're actually losing visceral fat as they're losing weight. Right? So the unhealthful fat that they're accumulating is coming off faster or more as a result of being more active as a result of, and combined with dietary changes. We focus on physical activity we think is more sustainable if it's done in real-world settings. We actually don't do a lot of physical activity with our kids within groups. We show them how to do more physical activity and what vigorous means and what moderate means, but we actually don't exercise per se with them because we think they need to get that in their community and figure out how it fits into their day. And we use an overall time-based model to try to increase the amount of physical activity they do at first, and then we increase intensity if in fact they get to that amount. We hope that our model is consistent with prior evidence about acceptability and lack of harm. We do encourage parents and kids now, if they can, get more objective monitoring. We think that's a reliable estimate of their physical activity, to use that as another proxy, because kids and adults aren't really great at reporting the amount of physical activity they do. And we also think that having this model and the way that we roll out physical activity to them includes contingency management and environmental control, and is helpful in that way. What happens if you do that? What happens if you provide a comprehensive, behaviorally based weight management program that focuses both on physical activity and diet and has that structure embedded in it? This is one of our earlier trials where we actually did a phone and mail-based intervention versus a very minimal, but what we think adolescents were typically getting in treatment, which is essentially one conversation with their physician and one follow-up. When you do the comprehensive intervention via mail or phone, not a very big effect, but lots of folks have demonstrated that, in fact, if you provide no treatment or minimal treatment to these kids, not only do they not get better, there's some studies suggest that they get worse. If you provide a comprehensive behavior modification program relative to just providing nutrition education alone, this is 3-month and 2-month and 3-month data. Len has actually followed these kids 5 years later, suggesting that the kids that got that behavior modification program or comprehensive program did much better than the kids that got nutrition education alone. If you provide treatment for 5 months and then provide additional treatment, these kids do better in the long term than kids that got no additional treatment 2 years later. More contact, no difference between these two conditions. These are just different content of those maintenance conditions. And again, this is a BMI Z-score, which is how we often measure some of these changes. A forest plot that you can't read. This is from JAMA from this year, and this was what USPSTF used to actually make recommendations for the number of contact hours that kids should be getting. Just want to focus on these particular dots, that one, that one, that one, and where is it? And that one. These are programs that actually saw kids for more than 52 contact hours. So the intervention was more than 52 contact hours. These interventions were 26 to 52 contact hours. Here was 6 to 25 contact hours, and here was less than 5 contact hours. You saw this dose response, right? So the more contact hours, although once you got below here, this is pretty minimal effect. You had to do at least 26 contact hours overall, according to this meta-analysis, to actually see an effect for treatment versus waitlist control or no treatment at all. Here, the numbers actually spelled out a little bit better. Multiple reviews and multiple meta-analyses. Through last follow-up, Mean and a Cochrane review this year found that they saw about a half a BMI point change, about a minus 0.06 BMI score difference between treatment versus control. Again, more contact hours, more effect. This is a really nice effect. I've never done a trial that had more than 52 contact hours. That's a really big effect. Janicki finds about half a standardized outcome, and then Ho back a little while back found a little bit higher and potent effect, but still an effect for the comprehensive weight management programs relative to everything else. 2010 was the first time that U.S. Preventive Task Force Services actually came out with a recommendation that was grade B, so meaning most healthcare things will at least attempt to cover those services. That clinicians screen for obesity in children and adolescents 6 years and older and offer or refer them to comprehensive intensive behavioral interventions to improve, for promoting improvements in weight status. How many folks here know about their local comprehensive intensive behavioral intervention to promote better weight status in kids? Wow, you're a pretty informed group and you don't know what that, okay. I don't either in my community. And we'll talk about why that might be and what we think we can do about it. So in an obesogenic macro environment, going back to that first slide, if children have healthful models, if parents and caregivers can change their microenvironments, their homes, other environments in which that kid is being cared for, if they set appropriate contingencies and caregivers are provided either change skills that lead to success, then this is made harder. This is a little bit easier. This is still hard, but in fact may not be necessary. Because most of the time we're encouraging our kids to stop gaining weight and to continue to grow as they don't gain weight, and then they cross BMI and BMI percentiles. So if behavior modification works and it's better than education alone, if we include parents as a target and that does better than just including kids alone, if we focus on diet and physical activity, that does better than diet alone and certainly better than just focusing on physical activity alone. And we know that longer treatment contact is related to better outcomes, then these are our issues. One, how do we get more families to adopt these evidence-based strategies? How do we do that? How can our current healthcare models integrate family-based behavioral treatment? And a lot of attempts have been made to try to lower the frequency of contact, but we saw what happens when you lower the frequency of contact. It reduces that ability to train families, it reduces the accountability, it reduces the opportunity for feedback. So these translations haven't capitalized on what we think are the strongest components of our treatment. Right? By definition, if you reduce contact, you're reducing all of those things. And yeah, I can kind of push out content, but that's just education. That doesn't include the accountability, feedback, or training. And then how do we better sustain initial effects of family-based treatment? We see inevitable relapse, not back to baseline as with adults. Again, Len has the best probably 5 and 10-year data to suggest that these kids are doing better than their parents are, and they're doing better than adults do in weight management programs. So why I'm so hopeful and why I continue to work with kids is because we've seen those outcomes. So we need a behavioral prescription that will result in expected health outcome. We generally know this. If we increase the diet quality and reduce caloric intake, as well as increase physical activity, we think we can get these outcomes. We need strategies that will result in successful adherence to the behavioral prescription, and we think that those skills help parents have their kids be more active and eat more healthfully. But most importantly, we need an intervention that will result in successful adherence to using these strategies. And to me, that's the unknown. But we think it will involve caregivers, particularly around family-based treatment. It's oftentimes telling for me to actually look at some individual data that we see from one of our trials. This is one of our trials. It's actually a 12-week intervention trial we did a few years ago. And I chose these kids not because they're a random set of kids, but because they all started almost approximately at the same weight, and they were approximately at the same height. And this is the pattern of results we got. This is a kid who lost weight consistently, and by the end was down to 45 kilograms from 53 kilograms. That's a pretty successful weight change for this kiddo. This is a kid who had a little bit more modest weight loss, and this is a kid who actually didn't lose weight at all, but in fact grew. So in fact, their BMI went down, and their BMI percentile went down. But this is huge variability in these outcomes, and we see this consistently in our trials. You might see those in other physical activity intervention trials where you see this vast variability. And we don't have a good understanding of why this happens. Why is this? And so our first attempt was to say, well, maybe this is not the right model. Maybe we need a different model that focuses much more on their motivations and enhances their motivations for doing these things. And maybe that will result in them doing more of these skills, feeling more efficacious, having commitment to doing these things, et cetera. So one of our first things we did a few years ago was we looked inward and said, maybe it's something that we're doing that we need to do differently. And we don't need a different dietary approach. We don't need a different physical activity approach. We just need to interact with families in a way that motivates them differently. So I've already described our prescribed approach, which I think is to prescribe these skills, expect families to use them, problem solve around better use of those skills, emphasize the importance of the skills. But you can take much more of a self-directed approach, or some folks talk about this as a motivational a motivational approach, an MI, a motivational interviewing approach, to ask permission to discuss the skills, to ask about readiness to use the skills, to pay attention to topics brought up by the kid and the parents, which may or may not be skills, and to empathize with the difficulty of actually implementing these skills. So a different tack that we're taking as interventionists that hopefully lead to different outcomes, but still have that intensity to our program. No difference between these conditions. We followed these kids, so this is during treatment. This is follow-up through 2 years later. No significant difference. Thankfully, our kids are doing better at 2-year follow-up than they were at baseline, which is fantastic. But they weren't doing any differently in terms of our outcomes. And when we looked at other outcomes, there was no difference. No difference in quality of life, no difference in how well the parents did in treatment. And what was really striking to us, that we asked families multiple ways to identify ways that they perceived us delivering the treatment differently, and they didn't. They didn't think we were actually delivering treatment differently at all. And in fact, some of the folks that got the prescribed approach reported feeling like we were being very self-directed and they were directing the treatment, and vice versa. And it got me to think, maybe we're looking internally too much, right? Maybe we're changing approaches, adding content, changing targets. And that's not what the prior evidence suggests to us we need to do. But for some reason, we keep doing this. We keep trying to figure out whether there's a different approach that we can take. And so a few years ago, I landed at this. I was talking with my intervention staff, and we were thinking about what is the possible next thing we do. These are the issues. We think we need to maintain the intensity of our intervention. We think it needs to be focused on skills training and having that accountability piece. We need to substantially reduce costs, right? 25 contact hours. I mean, I know the folks that made those recommendations. Does your health insurance cover you taking your kid for 25 contact hours to a provider to talk about these issues? Not at all. I don't know of any insurance company that covers those things for various reasons. We need to reduce costs, and most of our costs are driven by personnel, right? As my kids stated, this is not rocket science. I'm not doing procedures. I'm not doing medical interventions. We're doing what we think is highly sophisticated behavioral interventions, and personnel costs are really high. We need to improve the reach and availability of this intervention, right? To say that we're going to continue to do this in a way that folks have to come to us, and we're the experts, and there's only a couple sites around the country that do this is just not going to be helpful. And we need to sustain better outcomes. Those are the needs. So what do we do? What have other folks done? Maybe we try a different treatment format. And there's folks who are doing this, kind of the telehealth remote intervention way. That doesn't really actually reduce personnel costs if, in fact, there's a live person at the other end of that feed, but maybe there's a different way we can do that. Are there other healthcare providers that have the skills that we have as interventionists to deliver this intervention? Are there paraprofessionals or other lay health workers actually that can do this, right? So I have colleagues in other places that are looking at community health workers, promotorists, to see whether they can deliver intervention. We're sitting around saying, who knows this treatment well enough to deliver it, can do it at a significantly lower cost, can deliver its value and values, and be simultaneously empathic to families' challenges while holding high expectations for behavior change, right? To me, that's the $65 million question, at least in family-based treatment. Any ideas? Doctors? They're expensive. They're even more expensive than I am. So it took me a while to come to that. I should have come and asked you a lot sooner than this. That's why you got an award. We have treated hundreds of families, even thousands of families. They know this treatment perhaps better than I know this treatment. So we did a pilot. We called up families that were in our prior 3 trials, and we said, hey, how would you like to get trained on how to deliver this treatment and then deliver this treatment to families that we're seeing? That's what we did. We called up 50 people. 12 of them said they'd be interested in doing it. We brought in new families, and then we randomly assigned those new families to get treatment by us as professionals, or they get treatment by these peers. And again, these peers are parents. They aren't kids. It's not a kid-to-peer thing. These are parents working with other families in a way that we similarly worked with them. Oops. That's our EPICH trial. Our parent partnership project was similarly focused on trying to understand peer, but slightly different design. And I'm going to talk about both of them kind of intermixed, so I want to present this as well. In the parent partnership project, we brought in a generation of families that got baseline assessment. We treated them, and then we randomly assigned some of them to become peers for us, and some not. And then we exposed those folks that got randomized to be peers to the next set of families and said, okay, here they are. You got to treat them. Now, we trained them how to do treatment as peers, but they were randomly selected. We didn't select on any specific criteria for them to be peers. So slightly different approach to how we actually got the peers engaged in treatment with us. What were we interested in knowing? Can we train peers well enough to do this? These are folks who are not scientists. They're not behavioral interventionists. They're not healthcare providers. These are parents from various walks of life. Will they deliver the treatment in a way that's consistent enough with our approach to actually hit on those things like accountability, training skills, et cetera? How do families receive that intervention? Are they satisfied with the intervention? Do they drop out? God, this is a parent. This isn't a professional who's treating me. Do they drop out? And what's the impact on their weight status of kids and parents who got peer treatment versus got that professional treatment? And lastly, what about the peers themselves? So if I treat a family and that family treats the next family, do the family that did the treatment have a better long-term outcome because they spent 6 months providing treatment to other families about how to do this intervention? These are our EPICH peers. These are our parent partnership peers, 13 folks in all. We asked them after we provided training to them on a scale from 0 to 10, how confident are you to be able to deliver this treatment? 8.4, 8.0. Our behavior interventionists actually score lower than that. People we are professionals that we train. All these things are really high. They are really confident. Why were they confident? They spent 20 weeks getting this treatment from us. They spent 20 weeks working with their kids to try to implement this. A good half of them told me that they thought they would be better interventionists than we would be. And I don't doubt them. Throughout this, again, this is a 20-week treatment, family sessions, parent and child group sessions. Amongst the ones that, total number of sessions that treatment families had that were slotted for a peer. A peer was supposed to be treating them. There were 393 of them. Of those, the peers covered 392 of them. Their attendance at treatment, providing treatment, was higher than their attendance receiving treatment. Why? Because they made a commitment to other families to be there to try to help them make these changes. Our attendance at treatment is usually about 75%. Probably 14, 15 sessions out of 20 that we have in most of our treatment programs. This obviously is over 99% of the time a peer treated a family when they were supposed to. Sometimes things happen. Peers get sick, interventionists get sick. We looked at our professionals. 93% of the time, the professional interventionist that was assigned to a family to see that family saw that family, and 7% of the time, someone had a sub for them, a peer had a sub for them, or a professional had a sub for them. In the peer treatment, they had a little bit more subbing. Like, oh, you're another peer, I can't be there tonight, can you work with my family because I can't see them? And so they had a little bit more substitution, but again, most of the time they were treated by a peer if in fact they were assigned to be a peer, to receive treatment from a peer. What do we hear from them? What is it like being an interventionist? You received intervention, now you're going on to it. I really enjoyed growing with my families and getting to share my experiences with them. It's great working one-on-one with parents and kids to facilitate how they can incorporate these new skills and behaviors in a way that works for their family. I most enjoy the interactions with families and watching them struggle and grow. I feel like I help families celebrate their successes and their progress and keeping them motivated. This is exactly what our behavioral interventionists tell us. Right? So we train master's level folks to deliver this intervention. We ask them what that was like to actually treat families. They said the same thing as our peers do. We asked the folks that weren't assigned to be peers in that second trial, what was it like to not be a peer? Like you were randomly assigned not to be a peer. 6 months later, we did follow-up with them and asked them, what was it like not being selected? We were randomly selected. We didn't do anything to make it less like you would. I was surprised about the lack of compliance that I had during that 6-month follow-up. I was expecting families to try. This is their frustrations. These are peers' frustrations. I was surprised about the lack of compliance. I was expecting families to try harder. It was frustrating that family never tried monitoring. I feel they missed a huge skill. Again, exactly what our peers said. Some demographic stuff. I highlight this just to point out, we had a huge variability across different trials regarding income. And why do we get a huge variability in income? These programs aren't available to anybody. So we get folks in our treatment who are actually quite well off, and folks who are not. And less than 60 sounds high. The median income for our county is about $70,000. Our current housing prices in King County, the median house price as of last year was $650,000. That's how much you're going to pay for a single-family home in our county. So $60,000 isn't enough to actually get by, actually in our county. How much did the families accept the peer intervention that they got, right? These are ratings for people that receive professional treatment in EPICH, people that receive peer treatment. No difference between these things. People that got peer treatment liked it as much as the people that got professional treatment. And in fact, in some instances, they liked peers more than they liked us. That's very painful. We've been doing this for 25 years. Very painful to hear that other folks can do it better than I can. A little bit of dip, particularly regarding the parent group. We probably didn't train our peers enough to actually provide good parent group training, and we're working on that as we move forward. All right, most important thing, what are the outcomes? No difference between these in terms of how well the kids did that got peer versus kids that got professional treatment in terms of the child outcomes. No difference in the parent outcomes either. We looked at our parent partnership. These are folks that we treated through professionals. Then the professionals became the interventionists for these families. Not a randomized trial, so we don't compare them that well, but the magnitude of change wasn't that different between these. What happened to the kids and parents amongst the parents who became peers versus the parents who didn't become peers, who were randomly assigned? These are for parents. Parents who were peers between the post and 6-month follow-up. So they got treatment, they did their post-treatment assessment, they provided treatment, and then a week later we got their 6-month follow-up data, right? Because they were working with families. Their BMI went down. The parents who weren't peers, their BMI went up. And then through the total follow-up period, a difference, small sample size, we didn't even test this, but about 40% less weight gain amongst our parents who were peers versus parents who weren't peers. The effect is even bigger in the kids. These are the BMI Z-score changes. These are pretty high, so I'm not really confident in that estimate. But we didn't see any change in any relapse in the kids in the 6 months during which their parents were peers. A little bit of relapse then, but overall, probably doing a lot better than the parents who weren't peers. We never saw these kids again except for follow-up. These kids did not get additional training, treatment. They actually didn't come to treatment with their parents when the parents were providing treatment. We never saw these kids again. Something their parents were doing as a result of being peers helped them be more successful in the long term. Here's a slide I was referring to before, when we asked people who weren't peers about not being a peer. Being able to share and teach others would have been ideal for us. It would have been motivating. I miss the structure that being a peer interventionist would have provided. When you ask folks at the end of 5 or 6 months of treatment whether they want to continue treatment, they often say, no, it's been intense. I've had to put other things aside. I think I know how to do this now. When we ask these folks 6 months later, what would have been helpful about being a peer, they tell us the things that were exactly helpful about being a peer. When we ask peers about what impact it had on their own kids' weight status and their own, yeah, definitely. I brought back monitoring and getting my own physical activity in. Yeah, it was good to review the principles and skills. It also helped me gain a deeper understanding of what I had learned. Right? This is what folks do when they often teach. So I'm going to teach you, and then you're going to teach somebody else, and you get a better and deeper understanding of that when, in fact, you go through the process of teaching somebody else these things. What's the difference in cost between a peer delivering treatment versus a professional delivering treatment? A lot of cost to professionals doing it: intervention delivery, reviewing tapes, receiving training, treatment prep, supervision. It costs us in this trial, about $4,000 a family to provide that treatment. We paid the peers a $400 stipend for providing 20 weeks of treatment, which violates every single labor law I can think of. Some of them didn't even want it, but we gave it to them. For the peers, it was about $679 per family. It's about 1/7 the cost for a peer to deliver this treatment. And what are the costs for the peers? It was really us training them and supervising them. We provided a lot of supervision so they could do treatment well. The cost to actually have the peers and pay them was about $167 per family. Small samples. Feasibility for recruiting peers is not known because, in fact, we didn't recruit peers from people who had just received treatment. We recruited folks from prior treatment trials, and then in our parent partnership, we randomly assigned folks that we chose. We don't have any evidence for improved reach yet. And we trained peers to be like professionals. In fact, I think we probably did too much of that in encouraging them to be professionals rather than to being peers. Because one of the benefits of being a peer is that you're going through this, and you're probably still going through it to try to help your kid make these changes. So we sought larger funding to be able to do a larger trial looking at peer intervention, and this is our SHIFT trial. We want to explore the feasibility of recruiting, training, supervising, and having parents deliver FBT. We want a bigger examination of the short-term and long-term efficacy of peer versus professionally delivered FBT on child weight outcomes. We want to investigate the long-term impact of being a peer on the peer's own and their child's weight status. And then we want to see how many generations we can go out with this. So if I, as a professional, treat a family and that parent becomes a peer, the people that they treat, can they become peers? How long can we kind of perpetuate this? And then to determine the cost and the cost effectiveness of actually doing that. Very confusing design. We need to treat families, and I hate this word, but I can't think of a better word. We need to harvest peers from the people we treat as professionals so that they can treat other families, and then we can treat new families and randomly assign them to get peer intervention or get professional intervention. Some folks we just do follow-up on. Other folks get trained as peers from amongst these families that get treated by peers, and then they're treating new families. Thus the phases to our trial. Where are we at so far? 50 people have started treatment given by professionals. We've asked 38 of those families to actually go on and be peer interventionists based on attendance alone. I wouldn't say the word is argument. I had a back and forth with reviewers about whether I needed to set criteria by which I would choose my peers. My query back to them is, what criteria should I use? We don't know anything about any specific interventionist characteristic that makes these folks more successful in treatment. So I don't know that there's anything I would request a peer to be or not be in order to think that they would be a successful peer. 10 of these folks said they were interested and became peer interventionists. And we've got about 26% right now, 26% uptake of folks being peers. Now, we don't need it to be 100% because you can treat more than one family, but we probably need it to be closer to 33%. We asked these folks, all right, you received 6 months of treatment, and now you want to come back and deliver more. You want to deliver treatment. You want to spend your time, and it's evening time, delivering treatment to families. Why would you want to do that? Going through the content again would help me pick up things I didn't get the first time around. Our interventionist was great, a professional, but she didn't really understand all you're asking of parents, especially in the monitoring element. Parents who went through the program can bridge this gap by providing treatment to new families. I see this as an opportunity to give back to my community. Almost every single one of these parents mentioned two things. I think I'm going to benefit, and my kids are going to benefit from me being a peer, and I want to give back because I think it's something that would be helpful for other families. What have we found that's unexpected so far? We've had families cancel vacations notifications because they didn't want to miss sessions that they were providing treatment to families. I would say maybe not every week, every other week basis, our peers tell us how we can improve our intervention. And they provide content, and they augment the delivery of our intervention to make it, they think, even more robust. They suggest opportunities and ways that engage families more. They tell us about the challenges that they've had. They empathize with other challenges, but still hold high expectations for families. This is the one that kills me the most. This is a family that I actually work with, and this dad became a peer. And he said, you know what? I was supervising him while he was being a peer, which is also kind of an awkward relationship of, I provided treatment to you, now I'm supervising you and delivering peer stuff. He said, you know what, Brian, I've decided I'm actually going to implement this with the other kids in my family. I've been beating my head against the wall for months in treatment to try to encourage him to do that. Somehow being a peer made it click for him that he needed to do this with the rest of his other kids in his family. It's another thing that we didn't anticipate. Our first round of folks that became peers, we said, great, thank you. We appreciate it. Here's your $400, and here's some surveys. Tell us what experience being a peer was. And they said, wait a minute, we can't continue doing this? All right, you got treatment we got 5 months, 20 weeks. You delivered treatment for 20 weeks, and now you want to do it again? 3 of our peers are legacy peers. This is the second time around they've done this. We didn't ask them to be legacy peers. They said they wanted to do this. We asked them why they want to do this. I think I'm contributing, and I think it's benefiting my family by me being a peer and being here every week to do this. I didn't even know what to call them. My staff was like, should we call them 2-time peers? That just seems like a bad idea. So we're calling them legacy peers. I have no idea what that will look like in the long term, but we were surprised by that. So my question is this really family-based weight management intervention? And this is a model that, in fact, if we find efficacy, and I don't even know if it has to be similar efficacy to professionals, but if we do, and we see an impact of being a peer, is this a way we can disseminate this intervention? How do we encourage or stimulate or harness the power of peerness? I mean, I was talking with some folks who do the Promotor Community Health Worker program, and most of those folks haven't had the condition or been through the treatment that they're providing to folks. But they are peers in some sense, in that they're community members, that they share a common culture or community. But how can we harness that better? Of you've been through this, how do you help other families get through this and work on these things? Does this approach actually improve access equity? Right? What do we need to make adaptations? And Michael and I talked about adaptations before. Maybe we don't need to adapt it to other cultures, but maybe there's other cultural things around getting services or providing treatment from a parent as part of your community that is impactful. I don't know. You need to understand that. What is the dissemination system or model? I can tell you that my healthcare system isn't going to embrace this very easily, right? I joke, I'm a principal investigator at Seattle Children's. When I walk in the door with my kids, it's about a $400 facility fee just for walking in the door. Having non-professionals deliver interventions, they don't seem very open, at least right now, to how that could be. And peer-based approach may not be for every family. We need multiple models of intervention. Maybe there's some families that aren't willing and interested in being a peer or receiving peer intervention, and we have to figure out who that would be. I want to thank my team, my fellow interventionists and investigators, certainly NIH for funding this. Our pilots were funded by an R21, and by the Safeway Foundation to do pilot stuff, and our shift trial is an NIH and IDDK funded project. I think it's a safe word. I'm flabbergasted by what our peers do and how much time and effort they put into it. We actually kept track of their time in the pilot, just so we get a sense of, okay, if we tell folks in the future how much time they would be dedicating to this. And we try to minimize it, right? We provide supervision on site right before they do treatment, so they're just there for one night when they're doing treatment. We kept track of their time in terms of how much preparation they put in, how much supervision they got, training. It turned out that we're paying them less than $1 an hour to do this, right? Most of them are putting in many more hours than we expect. And they're really embracing this intervention and delivering it in a pretty high fidelity way. I still don't know how we're harnessing the peerness in the best way, but hopefully we'll get to that in a bit. Some references for folks.